Bifurcation lesions. There was some great data that came out recently from the October trial and OCT guidance versus angiographic guidance in bifurcation lesions. Tell me a little bit about that data.
Yes, important data, randomized trial comparing OCT versus angio-guided bifurcation with a superior result on the OCT arm, mainly driven by TLR, but also favoring OCT on some hard endpoints like stent thrombose. So these were complex bifurcation lesions that OCT guided performed better than angio only.
So that's some strong data to support the use of OCT in the instances of a bifurcation. In terms of translating that to practical use in the cath lab, help me understand, how do we actually implement that into our procedure?
Sure. So following the sequence of pre and post stent, on the pre-stent, I think you gain what you gain on any complex lesion as far as plaque characterization, calcium, no calcium, but specific for the bifurcation, you also gain something that is very interesting, is the actual angle of the takeoff of that branch. You can see this on the longitudinal mode. You can also follow the cross-section view, and if your side branch is running parallel like a dual lumen to your main branch, you would anticipate that some of this carina is going to be shift to the branch. But more importantly, you can clearly see how the plaque is distributed. So sometimes you might have a situation in which you have virtually no plaque on the ocean of the side branch, but you have a relatively shallow angle, and you have this carina being pushed away after you stent. That might represent some pretty tight lesion angiographically, but you already know up front that you probably should never stent this, either nothing or just ballooning, just to kind of even out that carina, because it's not plaque related.
Right.
So having this first look angle of takeoff of the bifurcation and plaque distribution will put you in a very strong position in anticipating what is next. There are a few things very practical that you also can take advantage of this first run, even deciding protecting or not protecting that vessel, right? So if the angle is good, if you don't have plaque at the ostium, well, you can save yourself a second wire and some time, and just keep work on the main branch.
Any other scenarios or things to think about in the pre-OCT assessment in bifurcation lesions, or is?
Yes, I think one very practical aspect is your stent choice. Remember that if you have a dominant bifurcation, you would anticipate a lot of vessel tapering. So one example would be a proximal AD lesion with a dominant first diagonal, in which your proximal reference area is a 5-0 vessel. Let's put it this way. So if that's the case, you're really going to need to make an effort to utilize a stent diameter of choice that can get you to that level of post-dilatation.
Right.
Right? And hopefully you find a landing zone distal to the bifurcation that could, if you're utilizing a Zion stance, that you could utilize a 3-5 that would allow you to grow all the way to 5 on the proximal segment.
That makes sense. In terms of, post PCI, looking at the max portion and bifurcation lesions, what does OCT provide the physician?
Yeah, so that would be again to your example, like the max, the edge, you're going to look in the same way. The apposition, you're going to look the same way, but you're only going to do that OCT run after you already post-due the proximal segment of that stent, right? Because you will anticipate that if there is a big taper of a stent, you're going to be malapose initially proximally. You correct that thing prior to the OCT run, and then hopefully you are well opposed. Then the next question comes, how do you assess expansion in a taper vessel? Remember, we have 2 modes. If you have a very dominant vessel, I find it very practical to go with the dual mode instead of the taper mode, which is, the taper mode is my default mode, but if you have a super dominant bifurcation, I think the dual mode apply well. And now you have your distal part of the bifurcation with a completely different target reference.
Right. In the the MLD portion of an OCT run and bifurcation lesions, talk to me about osteal LAD, osteal circ lesions. Are there any nuances there when we're looking at that type of, large bifurcation versus the bifurcation of, a large diag or OM?
Sure. I think the larger the branch become, there are some interesting tools or questions that you can answer through OCT. Example, if you are dealing with a distal left main bifurcation and you decide for 2 stent techniques versus 1 stent technique, the way you cross the cell might be relevant, right? So typically, if you are dealing single stent technique, you want crossing a more distal cell, so you have less metal in the new carina. If you are dealing with a 2 stent technique, you want to cross more proximal, so you make sure that your whole bifurcation osseous is still covered and you are not deforming too much the second stent, right? So what is available on OCT to help you that it would be 3D rendering of the stent that you can activate, and you can clearly see where your wire is crossing, right, if it's a more proximal distal cell. And that might trigger you reposition that wire before your kissing balloon.
One of the questions I get frequently is, do you think we're going to be able to get a good picture? And in the instance of bifurcations, where that really comes up is, very large vessels or osteal LAD lesions, osteal circ lesions. What is your experience there? And if it can be a trickier place to get an image, do you have any tips and tricks on how to get a good image in those instances?
Yes, I think it's more of a misconcept, and I think it comes from the fact that sometimes we use the term ocean a little too loose. We discussed already, like on image acquisition, that where you really draw the line, where you're not gonna get consistent image, is proper ocean left main, because you have too much of a flow in the ascending aorta. Now, when it comes to ocean LAD, ocean circ, or distal left main proper, you're gonna get consistently excellent image. We actually have a paper that we did a head-to-head IVUS and OCT comparison, and you have more information of dissection, tissue protrusion, malapposition, stent deformability on the OCT arm than you get with IVUS.
Okay.
So distal left main, OSH LAD, OSH circ is an ideal application of OCT.
And in terms of ensuring that you're setting a good foundation to get a good image in those cases, beyond good proper guide selection, are there any other things that we need to use or think about, or is just a good guide foundation sufficient to get the image that we need?
Yeah, is the basic principles that we already discussed before, and it's actually easier for you to get quality image on that segment than it is in a very distal vessel. Right? Is right there. Now, because it's a large vessel, yes, you need flow, you need a proper injection and a good guide engagement.
So let's talk about, as you just mentioned, usually these vessels are quite large. And on the OCT software in Ultron 2.0, the software does work to adjust the field of view based on what it's seeing. However, sometimes maybe we need that field of view a bit larger. And that's something that we can change in the case settings. How often do you find that once you adjust your field of view that you are or are not able to visualize everything that you need in those types of lesions?
Yeah, I think what you stress as you need is important, right? Because again, typically your question is more related to the distal bifurcation of the left main, and you have plenty of field of view to capture all that.